We will take up three cases. One regarding the therapeutic levels, how to monitor clinically, more than investigational methods, how to monitor clinically with regard to drugs, of course. And second one, how to manage a case. If at all, if a patient comes just like that or for a surgery or anything else, how to manage a case, how to plan the management. And the third one is the interpretation. Okay, so we will see one by one, and let me go a little more faster. If there are any, you put some questions, we will try to give you the answers. So the first one is based on the therapeutic levels. Based on the therapeutic levels. Okay, 85-year-old was admitted. You please catch up the important words here so that we will go accordingly. 85-year-old lady was a geriatric patient admitted from a nursing home to an emergency department, complaining of shortness of breath, sensation that the heart was racing, means tachycardia, denied symptoms of chest pain, cough, reported feeling well, uh, with intermittent episodes of palpitation. Past medical history, the diagnosis is hypertension, IHD, CHF with atrial fibrillation. Also, she had a community acquired pneumonia. So for that, the treatment is already over, but her regular medications being ramipril, benzoflumetazide, and digoxin. So you note down the doses, the route of administration, as well as the frequency of administration. So with this, we will just summarize the whatever is there here. The case overview, 85-year-old female, she's a geriatric, worsening of shortness of breath and racing heart, that is most often atrial fibrillation or tachycardia, like that. The past medical history, there's a whole lot of diagnosis, hypertension, IHD, AF, CHF, and previous pneumonia, and the medications are as said above. The clinical findings are pulse being 140 beat per minute, irregularly irregular. Blood pressure is low, 140, 104 by 70. Oxygen saturation is 97. Jugular venous pressure is not elevated. I'll show you the ECG later. Atrial fibrillation with rapid ventricular response. And chest X-ray at present, after suffering from previous pneumonia, there is clear lung fields. These are the clinical findings. So now, with all these, we will just, I told you the important points, no? We will just go through what all is there in all these cases and then come to a conclusion. What is the problem here and what we have to monitor to bring her back to normal, so to say normal, to lead a good quality of life. So, as she is having atrial fibrillation, we are supposed to give anticoagulant therapy because there might be thrombus which may go on to the brain and cause stroke or even DVT, etc., etc. So the purpose of anticoagulant therapy is to prevent and treat thromboembolic events if it occurs. And the common medications which we are using are warfarin on a OPD basis, vitamin K antagonist, heparins, mainly the unfractionized in ICU. Low molecular weight like enoxaparin can be used on an OPD basis, but quite costly. And I'm just giving you an overview. Any more information you want, you please tell me, because we have already dealt with this. Now it is more than warfarin. We are using directly acting oral anticoagulants, that is DOAC. Dabigatran, rivaroxaban, and apixaban, looking at the creatinine value. The main indications for these are atrial fibrillation, mechanical heart waves, and venous thromboembolism. Monitoring definitely required because the main adverse effect is bleeding, which can lead to hypotension. So with warfarin, we always want INR ratio, which is targeted to 2 or 3 in most of the cases. And with heparin, especially with unfractionized, we want APTT And with LMWH, we want anti-XA levels. And regular renal and liver function test for direct oral anticoagulants. This is the summary or the brief overview to recollect when you are looking at the patient. The adverse effects, as I told you, mainly bleeding, bruising, hematoma, or with apparence, there is heparin-induced thrombocytopenia hit. And the patient education with regard to these are, whenever we add anticoagulant therapy, the importance of adherence is most needed, because even if they change the time, or even if they skip one day, or if they take without knowing one more overdose, or if they take some of the drugs, drug interactions are very common. So the adherence is more important. I hope all of you know the difference between adherence and compliance. Then avoid OTC medications, especially NSAIDs, and without consulting, no drug should be taken whenever the patient is on anticoagulant therapy. Dietary precautions, especially with warfarin, because drug interactions are more known to occur. The reversal agents for these are vitamin K and fresh frozen plasma, as the situation might be for warfarin, protamine sulfate for both unfractionized and low molecular weight heparin. But protamine sulfate itself is an anticoagulant. So if you stop this unfractionized heparin or low molecular weight heparin, you are almost treating the case instead of giving protamine sulfate and making it another anticoagulant. And specific antidotes for DOAC nowadays we have, especially for dabigatran, that is idarucimab. These are the overview of the anticoagulant therapy, if at all we want to give, but the patient has got only 140, maybe just tachycardia. Maybe to tide over the crisis, it might come to normal after observations. The second is the patient is suffering also from atrial fibrillation, where we have to note down the rate rather than the rhythm. The four commonest groups of drugs which we use as heart rate lowering agents, depending on the priority. Depending on the priority is beta blockers, most often metoprolol, but occasionally bisoprolol also. Most often the metoprolol has got selective beta 1 activity, that is cardio selective only, whereas bisoprolol in addition has got nitric oxide activity, vasodilatation, so they may decrease the blood pressure also. Regarding calcium channel blockers, diltiazem is better than verapamil in decreasing the rate, maintaining the rate, and verapamil and beta blocker cannot be used together because both of them decrease the heart rate and can lead on to heart block. So diltiazem is better in any way comparatively. The third in the line is digoxin because of its narrow margin of safety, which we'll be talking later, and also therapeutic drug monitoring. So if we cannot afford therapeutic drug monitoring, clinically, what sort of therapeutic drug monitoring can we do? The last one is for the one which acts on funny channel current, that is ivabradine. This is mainly indicated whenever the heart rate is not under the limit or not below 90 or 70 with metoprolol. If it is so, then we add ivabradine. Otherwise, most of the times we keep it as a reserve. Now, overview of digoxin, though this is not at all used nowadays, but still we would like to know this because lastly, to decrease the morbidity, it will not decrease the mortality, it will decrease only the morbidity. And in certain cases where we are somewhere outside, then in such cases, we need to put digoxin, or even the cost effectiveness also matters. So in such cases, we have to put digoxin. So in such cases, what are the important points to remember? The mechanism of action is inhibition of sodium potassium ATPase. So don't confuse with sodium hydrogen ATPase, because you have it in proton pump inhibitors. Most of you confuse for this, especially in MCQs. So don't do this. sodium, potassium ATPase to increase the intracellular calcium. First, there is blockage of this one between sodium and potassium. As sodium increases, there is exchange 2:3 with sodium and calcium. So then there is, because of this increase, there is a stimulation of sarcoplasmic reticulum, myosin light chain kinase system. And hence we see both positive inotropic effect, which improves the contractility, and also there is negative chronotropic effect, which reduces the heart rate, especially in heart failure. There is already sympathetic activity, especially in acute heart failure. So we cannot decrease it with drugs like metoprolol or other heart rate lowering agents. So we want such a drug where it improves the heart contractility, the contraction, whereas maintaining the heart rate or reducing the heart rate. There are only two indications for digoxin, that is heart failure with reduction ejection fraction and rate control in atrial fibrillation, when it is not sufficed by the first two groups of drugs. The problem or the important thing what you have to consider is the narrow therapeutic index what we see, and also the serum level monitoring is very essential. It should be between 0.5 to 2 nanogram per milliliter, and the toxicity risk increases with levels more than 2 nanograms. There is a high risk of toxicity which can be both cardiac as well as non-cardiac toxicity. So the non-cardiac toxicity is mainly nausea, vomiting, visual disturbances. Why is it so? Because it also stimulates vagus. Physiologically, vagus is depressant to the heart and it is stimulant to the stomach. So when there is stimulation of the stomach vagus, there is nausea, vomiting, and also there is small innervation in the eyes. So there is also visual disturbances, that is yellowish green halos. In cardiac toxicity, we do have both atrial and ventricular, both bradyarrhythmias as well as tachyarrhythmias. For atrial tachyarrhythmias, as I told you, the heart rate lowering agents are the main ones which are used. And in bradyarrhythmias, most of the times we use atropine. Nowadays, we are using glycopyrrolate. Okay, so next, and if at all, if it is due to sympathetic activity only or beta blocker toxicity, then we use even isoprenaline. Next, with regard to ventricles, initially we have pulsus bigeminus tachycardia, pulsus bigeminus, and later on fibrillation. So for the first two, you can stop the drug or even give a little bit of potassium. Whereas for the last one, you have only two drugs, ventricular arrhythmias, digital is induced. That is both lignocaine. Alternatively, we have phenytoin, both are sodium channel blockers. These cannot be used in atrial arrhythmias. In atria, the current is a slow current which is mainly calcium dependent. Lignocaine and phenytoin will do not work, and hence it is not used in atrial arrhythmias. It is used only in ventricular arrhythmias, more so digoxin-induced ventricular arrhythmias. And whenever we want to monitor these digoxin levels, we have to measure 6 hours post-dose or during steady state, and regularly check the renal function, potassium and ECG, because we do give, because of edema and other things, we do give hydrochlorothiazide or benzohydrochlorothiazide, where it can cause hypokalemia. And so because of that, you have to monitor potassium. And as they are excreted by renal, you have to know the renal function, because the accumulation in the muscles and also cumulative toxicity is more seen, and ECG, of course, to know the further things. The toxicity risks are increased with hypokalemia, renal impairment, and interacting drugs, especially with antiarrhythmic drugs, which are all proarrhythmic, and also diuretics, mainly the furosemide, thiazides, and whenever we give it spironolactone, it can even cause hyperkalemia. If at all the patient can afford, and if it is a big hospital, the treatment's toxicity is with FAB antibodies, that is GG-Bend. So the important points for in case of digoxin to remember is it has got a narrow therapeutic index. Serum level monitoring is required. Too low, there is no clinical response. Too high, there is toxicities, and long distribution half-life. So monitor only for 6 hours, after 6 hours or after 2 weeks, and especially in patients with renal impairments and in patients who are prone for increased risk of toxicity, like patient taking drugs which may interact and those who have hypokalemia. It's very important, and it should be remembered that there should not be overlap between therapeutic and toxic levels. So which are the drugs which cause narrow therapeutic index? So basically, what is therapeutic index? Therapeutic index is normally 1 and it is measured by LD50 over ED50. So if it comes as 1, we don't bother. More than 1, we never bother at all. Below 1, we definitely bother. And most of these drugs, they want loading dose and then maintenance dose. This is also another problem. So we require both therapeutic drug monitoring because of narrow therapeutic index. So these 2 points should be remembered at any given time, everywhere and anywhere. So these are few of the drugs where we are using day in and day out, and these are the ones which have got narrow therapeutic index. Digoxin, NCCF, phenytoin, anti-epileptic drug, lithium, bipolar disorders, which is not used nowadays. Warfarin, an anticoagulant. Again, we have got directly acting oral anticoagulant. Busulfan, anti-cancer. Aminoglycosides, the antibiotics. We have to be very careful whenever because of narrow therapeutic index also, and also in patients who have ototoxicity, nephrotoxicity, and neuromuscular blockade, and those patients who are on nephrotoxic drugs and ototoxic drugs also. And in patients with myasthenia gravis, these aminoglycosides should not be used because we are going to add them with neostigmine. Nowadays, the choice is immunoglobulins. Carbamazepine, again, we use it in as anticoagulant drugs, anti-epileptic drugs. Argatroban, we use it as a directly acting oral anticoagulants. Lamivudine as an antiviral drug. Tacrolimus not only as an anti-cancer, we also use it in stents, drug-eluting stents. And theophylline, we never use it because of its severe toxicity. We have got better drugs nowadays compared to theophylline and aminophylline, though we use doxycycline in chronic cases. In other cases, we use beta-2 agonists, antimuscarinic drugs, and corticosteroids in asthma. So this is the ECG which is shown for atrial fibrillation with rapid ventricular response, and T wave inversions are seen. Okay, T wave inversions, T wave inversions are seen in lead 3, 6 and V2. Lead 3, that is here, lead 3 where we see this T wave inversions. Then again in 6 we see T wave inversions here. Okay, and then V2 also we see very beautifully these things. So here you have to be aware that the patient has got all of them all in all. So you have to be careful in seeing these things and then admitting or thinking about the future drugs, what we really can do it. So the main question which is posed with this problem is, what is the next drug of choice for the acute management of this condition, and how will you assess whether the patient is on appropriate dose of digoxin? So before that, we will just rush through this so that we are using all these drugs and we have to know about the main side effects, so that whenever we can try to avoid and see that the patient is clinically normal, not going to any unwanted investigations. Okay, so we normally use thiazides both in hypertension and CCF, that is along with digoxin. Calcium channel blockers whenever the patient is in really bradycardia, or if the afterload is very less, or isolated systolic hypertension. AC inhibitors, of course, the drugs of choice, both AC and ARB, both in hypertension. That's why we don't see so much of congestive cardiac failure. If at all, these has been treated with the initial hypertension itself, so that we are decreasing the problems of CCF, because these are mixed vasodilators and they take care not only of the blood vessels, they take care of the heart also. They act as anti-arrhythmic also. They give good blood supply to the heart also. And also they decrease remodeling, they decrease fibrosis, and they decrease apoptosis. With all these things, majority of the problems are decreased, and the patient can survive nearly for 30 years with these drugs itself, provided the patient is also aware and the doctor is also aware, asking them to come for regular checkup so that the BP is very well maintained. Beta blockers, mainly we are using bisoprolol, nebivolol, metoprolol, carvedilol, These are the drugs which are very commonly used nowadays on an OPD basis, so that the patient has got an optimal heart rate, not having a sympathomimetic activity. In loop diuretics, we use low dose on an OPD basis. These are only for ICU basis, where we want to decrease the blood volume instantaneously, and also in certain poisonings. Potassium sparing diuretics is also sometimes known as a heart failure drug nowadays, one of the most important drugs, but we have to be careful. The most important point is hyperkalemia and anti-androgenic effects on a longer scale, but at that minimum dose, we are fearing more about hyperkalemia than the other things. Hydralazine is used mainly in the resistant cases, so also alpha-2 agonists like clonidine and minoxidil. The problem is hirsutism. We use more in hirsutism than as refractory CSF. So also or alpha blockers, where we see mainly first dose hypotension, and tachycardia is seen with non-specific. With prazosin, we mainly see first dose hypotension and no tachycardia because it's a selective alpha 1 blocker. So, which are the main drugs used in CHF? The anti-mortality drugs are beta blockers, ARNI, SGLT2 also is one of the main drugs nowadays, AC inhibitors and ARBs. So all of you know all these things. That I'll just tell the key effects. They improve the survival rate and reduce the hospitalization, and increases the ejection fraction, beta blockers, and avoided in acute cases. Avoided in acute cases. Okay, so next ARNI, this is used only when these are not effective. ACE and ARB are not effective, and when the ejection fraction is below 35%, then we add sacubitril with valsartan. So you have to continue these drugs before these, you have to avoid these drugs when you start adding this. Otherwise, there might be even angiotensin, this escape phenomenon also. So here it reduces CV mortality as well as hospitalization, and these trials have shown that we have to avoid these drugs simultaneously. AC inhibitors, very well known fact. ARBs also. These ARBs, amongst ARBs, telmisartan is the one which is very commonly used, and AC inhibitors, ramipril, have got a good effect, and more number of clinical trials is given. Both are contraindicated in pregnancy, heart failure. Now, the drug of choice is SGLT2 inhibitors because of two or three reasons. It does not require insulin, so it can act as an anti-diabetic drug also. Okay, without insulin, so it is a very good effect. Then we can use it in heart failure also. And thirdly, it will act as a diuretic also. And fourthly, because of these effects, there will be weight loss. So it can be used to a certain extent as no as an obesity anti-obesity drug also, to a very minimal extent. So these are the ones which are the main drugs of choice in heart failure, where we have to see these should be there. Apart from this, even the mineralocorticoid receptor antagonist. Now we were using spironolactone. Later we chose eprillinone. Now we are using phenyrenone. So all the other ones, nitrates, hydralazine in resistant, ivabradine only when only for sinus rhythm when the beta blockers is maximized or contraindicated and the heart rate does not reduce below 90. The newer drugs are very Quat. The last choice is digoxin, and these have got known to cause reduced mortality, which is used only as an adjuvant therapy. Used only as an adjuvant therapy. The last one are potassium binders, where in case of hyperkalemia, we are more seen, and together, if at all, they are more prone for renal failure, potassium accumulation might be there. In such cases, we use this potassium binders to monitor potassium levels. And diuretics, most often nowadays, we are using torsemide, but in ICU, furosemide is the drug of choice, which can relieve congestion, reduce symptoms, and in acute cases, whenever there is pulmonary edema also. So now coming to the conditions where we see so many conditions, but what really we can administer. Okay, so in such cases, See, all these are acute coronary syndrome, ischemia, acute myocardial infarction, and later on IHD or chronic coronary disease. These are the stages which it goes on. So in each case, the ultimately we have to add all the drugs. The all four anti-mortality drugs should be added, but in acute cases it differs. It differs. Okay. So in acute coronary syndrome, normally when we use this P2Y12 inhibitors, that is prasugrel and ticagrelor. Nowadays, ticagrelor is the drug of choice. The only problem is bleeding. Otherwise, this has given the maximum benefit in all cases where we normally use 180 milligrams. And high dose statins, that is 80 milligram statins, because they decrease. Not only they act through HMG-CoA reductase inhibitor, it also causes pleiotropic effects, anti-thrombotic, anti-inflammatory, plaque stabilization, and also decreases the triglycerides as well as cholesterol levels more than 50 to 70%. That's why we use high dose statins. Beta blockers, in acute coronary syndrome, we are supposed to use very low dose if the heart rate is above 70, above 100 or more than that. In non-STEMI, we use mainly heparin or enoxaparin, early invasive therapy for TIMI greater than 2. Greater than 2. Okay. So these are the one. And in stable IHD, as I told you before, we apart from those drugs, we will use aspirin as well as statins. Long-acting calcium channel blockers are added like cilindapine. Nitrates, if at all, if the patient has got any exertional angina, and ranolazine is a metabolic activator. And if it is not sufficient with these, then we add ranolazine. Otherwise, we do not add either ranolazine or trimetazidine. And dual antiplatelet therapy for about an year, and later on you cut down to a single drug. Then long-term anti-epileptic therapy, antiplatelet therapy with clopidogrel 75 milligrams and aspirin 100 or 150 milligrams after initial DAPT. So most often we give it for 1 year, and after that, if we suspect or if there is high risk, in such cases we use both the drugs. Otherwise, either clopidogrel or aspirin is sufficient. More than aspirin, clopidogrel is better, because aspirin, when the patient is taking aspirin on a regular basis and lifelong, there is 5 ml of blood loss every day. Every day there is a blood loss. So these might be the problems. So clopidogrel might be better, but we have to think about neutropenia in this case. As I told you, heart rate lowering agents here with the conditions we have just seen here. If it is quite stable, then we use rate control with metoprolol or diltiazem, and digoxin or amiodarone only when the heart failure is present or beta blockers are contraindicated. When are the beta blockers contraindicated? A, B, C, D: asthma, block, coronary heart disease, and diabetes, especially non-specific beta blockers. In unstable angina, prior to TE, if RVR is causing instability, in such cases we do so. Now these are done to maintain the hemodynamic status, whereas for rate control, the first drug of choice anywhere and everywhere is beta blockers, that is IV metoprolol. If not, then diltiazem, but we have to avoid it in heart failure, and also reduce ejection fraction. Lastly, we consider digoxin whenever there is a stage 3 or 4 failure, we use it, or when there is contraindication to beta blockers or CCBs. Amiodarone can be used both and for especially for rhythm control whenever there is heart failure is present. For rate control, mainly metoprolol, verapamil, diltiazem, and then verapamil, then digoxin, then nivabredin. Whereas for rhythm control, we use amiodarone. And in anticoagulation, to assess the risk stroke, if it is in the low risk, we don't add any anticoagulants. But in score 1, we use anticoagulant or antiplatelet therapy. Whereas in moderate or high risk, we use, as indicated, warfarin or directly acting anticoagulants. The bleeding risk assessment should be done using this Has-Bleed score to assess bleeding risk before initiating the therapy. Non-pharmacological therapies, I think all of you know better. These are few of the non-pharmacological therapies what we are having today. Now, regarding the cap, a brief view I thought, because though the patient is not suffering, if you have this, because nowadays infectious diseases have become very common, and also antimicrobial resistance is common. So everywhere stewardship is going on. So for that reason, I thought I'll just give you a glimpse of these drugs where it is used if we have comorbidities or no comorbidities. So on an outpatient basis, with no comorbidities, we normally use macrolides. Amongst the macrolides, we prefer clarithromycin or azithromycin because of four adverse effects of erythromycin. The adverse effects are mainly enzyme inhibitor, then estolate will cause the gastritis, and then you have it should be given 4 times daily, and there are a lot of drug interactions with that, and it is also a CYP inhibitor. So these are the problems. So we normally use azithromycin because it can enter even macrophages, or doxycycline, the good old drug, that is the tetracycline, which has got advantages over the other tetracyclines. That is, that can be given once daily. Then it can be given both in renal failure and heart failure, sorry, hepatic failure, and it should be given. It is absorbed completely, 100% bioavailability, and it is excreted in fecal matter. So these are the these are the good things what we have. So normally we use either azithromycin or doxycycline. On an outpatient basis, we use with comorbidities, we use levofloxacin, which is named as respiratory fluoroquinolone. Moxifloxacin and gemifloxacin, we commonly don't use it because of its QT prolongation. QT prolongation. Or if we are not very confident with these fluoroquinolones, we normally use this amoxiclav or cefuroxime with clavulanate, or again come back to macrolide. One of the macrolides, mainly azithromycin. In an inpatient with non-ICU, we use respiratory fluoroquinolone, that is levofloxacin, or the combination with ampicillin sulbactam or ertapenem, that is carbapenems, or cephalosporin, second and third generation. Inpatient, we normally use a combination of beta-lactam with macrolide or beta-lactam with respiratory fluoroquinolone. Both of them should go simultaneously. With aspiration pneumonia, ertapenem is really good, and it can cover to an extent. To an extent, it can cover even anaerobic. With risk of pseudomonas, all anti-pseudomonal penicillins as well as cephalosporins and fluoroquinolones with aminoglycoside and azithromycin. All these should be taken care based on the pathogen and given for a very long time. MRSA, all of you know, rifampicin, vancomycin, or linezolid is the drug of choice. Rifampicin, first line anti-tubercular drug, but fear of enzyme induction. Vancomycin IV, we fear of hypotension and red band syndrome and sudden death. Linezolid, we fear of thrombocytopenia. Legionella pneumonia, fluoroquinolone or macrolide. And psittacosis or tularemia, again macrolide or doxycycline, as we see in the outpatient with no comorbidities. In case of fungal, we use either itraconazole mainly, but if it is outpatient basis, we can think of high dose of fluconazole also. In virus, it is oseltamivir, and critically ill patients, adjuvant corticosteroids, and in certain cases like necrotizing pneumonia or abscess, we have to do tubal drainage, surgical decortication, and antibiotics, where based on the resolution, we have to extend it for 3 to 4 weeks also. So here, now we will just go through this. The one more important point what I wanted to tell you was drugs which require drug holidays. Drugs which require drug holidays. What do you mean by a drug holiday? This is clinical TDM. Okay, whenever you want to do a TDM, patient should be in the clinic for about 6 hours, because we have to take it at steady state plasma level concentrations, or it should at least get some peak level. wait for 6 hours. So many things are there. And affordability. Each time they have to spend at least, the least of the least, they have to spend 1,000 rupees. So each time 1,000 rupees, it is not possible. So clinical TDM is drug holiday. So what do you mean by that? Because of accumulation, all these drugs will get accumulated in the body. For example, digoxin in the muscles. Okay, so like this, they get accumulated and slowly they get released when the concentration is low. And that itself might be one of the toxicities what these people encounter. So to avoid all these, you make a regimen saying that Sunday is a holiday. So skip the drug on Sunday, so that when they skip the drug on Sunday, the most often the levels would have come back to almost near normal. So whenever you start from Monday to Saturday, the whole problems are solved. And so clinical TDM can be done very effectively. If at all you know where the problem is, then we can give drug holidays in such cases and be done with it. And most of these drugs nowadays we are not using now because we've got better drugs. Like for digoxin, we have got anti-mortality drugs. For SSRIs, we mainly use the last one, that is citalopram. Instead of levodopa, we are using pramipexole. Instead of lithium, we are using lamotrigine, sodium valproate, etc., carbamazepine. And in HIV, we are always using combination drugs with triple drug regimen and combination of protease inhibitors or NNR, NTRI and NNR. So these are the things what you have to know these things in these cases before you administer. So you should be confident when you are administering these things. The other important points are mainly who are experiencing atrial fibrillation with rapid ventricular response. Mainly we use repeatedly, I'm telling you, the drugs of choice are beta blockers, calcium channel blockers, and only then digoxin. Why last digoxin? Because of low therapeutic range. I told you what is that narrow therapeutic range, and taking digoxin may have their serum digoxin concentration level measured to ensure that they are not receiving the drugs, the doses too high or too low, which is a very big issue in monitoring. So better give drug holidays for that and get sufficed by that, so that the patient can also be happy without much financial burdens. So with these in mind, what was the problem, what was the current medication review we will do. That is digoxin 125 micrograms OD. So it may be high for elderly patients with possible renal impairment. Then bendroflumetazide, which is nothing but a thiazide diuretic. When added with digoxin, it causes hypokalemia, increasing the risk of digoxin toxicity, leading on to cardiac toxicities. And hence the combination issue is mainly digoxin and bendroflumetazide. So these are the problems what we encountered in that case, whatever we saw in the first slide. Now, what are the recommendations? After having known what the theory, what is done, what we do normally, or if you have forgotten, or when you have read it in pharmacology, or during house surgery, or consulting, whatever it is. Now, coming to the management portion, because of those problems, what can we better do in an acute management? Metoprolol, calcium channel blocker, mainly diltiazem, for rate control. Rate control. Avoid digoxin escalation because of TDM, because of narrow margin of safety. We have to see that it is in that therapeutic range. So many problems are there. So these are the better ones, and maintain the heart rate between 60 to 90 with metoprolol and diltiazem, which can be maintained very effectively. But if at all the patient is already on digoxin, so may monitor the serum digoxin levels and electrolytes. Why electrolytes? Potassium and magnesium mainly, because it is known to increase digoxin levels and also renal function, as digoxin is excreted by the kidneys. So how do you do this adjustment? The second, this one, we have lower the digoxin dose based on the toxicity signs, or give a drug holiday so that the patient will not go on to atrial fibrillation. Now, I want to give you one question, that is digoxin is used in atrial fibrillation and it also causes atrial fibrillation. How can it be? Any idea? Anybody can post it, post this question. If not, I'll tell you the answer in the next class. Digoxin causes atrial arrhythmias. Okay, digoxin causes atrial arrhythmias and it is also used in atrial arrhythmias. How can that be? That is the question, and I want to know that. And in any bradycardia, we use atropine and isopranaline. Where do you use the specific indication for atropine? How does it act? And isopranaline, how does it act? And where do we use these drugs to increase the heart rate? So, in summary, what are the key takeaways? The diagnosis is atrial fibrillation with rapid ventricular response. Medication concerns are high digoxin dose and interaction with thiazides. The priority is rate control and digoxin level monitoring. These are the priorities what we needed in that case study. Okay, so you have to monitor it like this in case of therapeutic levels, but therapeutic drug monitoring is a very tedious process, especially from the patient side more than from the doctor's side. And so clinical TDM, remember this day in and day out, clinical TDM is always a drug holiday. Drug holiday, and avoid, in most of these cases, avoid digoxin so that you are avoiding all these interactions, you are avoiding potassium problem, you are avoiding atrial fibrillation. Okay, all these are avoided. So you start with anti-mortality drugs, AC inhibitors or ARBs, then beta blockers, metoprolol or bisoprolol or even carvedilol. Then thirdly, you add mineralocorticoid receptor antagonists. Nowadays, we are using phenindrone because of its advantages, and more so SGLT2 inhibitors because of their greater beneficial pleiotropic effects. They have got 10 pleiotropic effects. So we are using those drugs nowadays. Or we are avoiding many of these problems, and the patient can go even for work. As we see the patients with renal dialysis, they just go to renal dialysis and later on they go to the shift of 2 to 10. So likewise, you can make out that the person or the patient can lead a good quality of life with all these things. So actually, we have to maintain the therapeutic levels, but we can avoid all these in this era because we have got very good drugs for all the conditions, for all her diagnosis. So you can just see over all her diagnosis, you can think of better drugs what I have enumerated just now. Okay, so these are the one I'll just show you. See, hypertension. Best is AC inhibitors, ARBs. Okay, with one of the diuretics. Ischemic heart disease. Again, ACA, ARB, beta blockers, antiplatelets, statins. Atrial fibrillation. We have got directly acting anticoagulants where we need not monitor. Heart failure, as I told you, anti-mortality drugs, all 5 drugs, and if the ejection fraction is low, we can add RD. Previous pneumonia, we have given you all the combinations of drugs what we can use, but it should be used in an optimal doses with good frequency, and also the duration of all the 4 should be taken into account. Patient, if we say take for 7 days, they might go and take you just for 4 days and saying that the money was not there. So these are the problems which are met. So you have to be careful whenever we are choosing this. So when we use these drugs, the drug interactions are very much minimized and the patient can have a good quality of life, which is our aim since about a decade or so. Okay, so these are few of the things at therapeutic drug monitoring level, or therapeutic levels to maintain or not, so how we can really manage and get along with these drugs. So both the questions are answered in this problem and you have got an overview of all these things. Okay, so now next we will go to we'll go to the planning management, and lastly we will go to the okay. The second case is the planning management. So what do you exactly mean by these are the ones which are coming up nowadays? Even when you want to go to USA, USMLE and all, they ask these sorts of things, and you have to really be communicative. So planning management, you can't just say in one word and forget it. So we have tried to give some options and try to solve it. So we'll just go through this problem. A 65-year-old man attending GP surgery for a routine clinical review. He has been feeling well and had not experienced recent illness. Past medical history is type 2 diabetes mellitus, which the patient is attempting to control with dietary and other lifestyle modifications over preceding 6 months, and no drugs. For T2DM, no drugs. Maybe he is pre-diabetic and hypertension. The regular medications are Ramipril 5 mg, AC inhibitor, amlodipine, that is CCB 5 mg. No known drug allergies. He works as a window cleaner. So you can imagine his financial constraints. Drank 20 units of alcohol and weekly, and was a current smoker of 10 cigarettes daily. So this is the history what we have with the patient. So the details, as I've told you again, once more, only he might be pre-diabetic or is controlling with lifestyle modification. Lifestyle modification, don't say diet and exercise. Use the word eating habits and also the physical activity. Then only they will be able to understand you. If you tell them diet, they'll say, yeah, I'm doing diet since 20 years. If you say exercise, yeah, every day I do exercise. But what is that exercise? You will also not have time to listen. They will also say anything and everything. So for that reason, always tell them what is your eating habit, so that you will come to know what should be eaten, what should not be eaten, and how many times it should be eaten. Or can you give somewhere about 8 hours of gap, so that you will giving rest to the pancreas and also increasing the insulin levels. And for physical activity, don't tell them exercise, you tell them physical activity. God has made us to walk, 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 walk. That is the best thing. Max to max, you can include small exercises, because in elderlies, there are a lot of other problems. So you have to be careful whenever you are talking about exercise or physical activity. For hypertension, these are the drugs which he is using, and he is a smoker, alcohol, and allergies are not. So on examination, he's overweight. Otherwise, everything is normal. Laboratory investigations are almost normal. Most of the things are almost normal, including the electrolytes, uh, even the creatinine. Little it has decreased eGFR. HbA1c is again normal. Okay. So based on these, now I have given several options. So which can you think? Or we will revise it one by one and come to a conclusion. What best can we do in this patient? So advise further 6 months. So please remember the slide. This slide. Remember this slide in your memory. Okay. So remember this slide, especially second slide. So we will go to these questions. See, based on the results, what is the following options is the most appropriate ones? Okay, so here the first option is advise further 6 months of lifestyle modifications. Okay, think about his age. The second option is commence glycoside 40 mg OD and titrate dose up over the coming weeks. Glycoside is a sulfonyl urea. Glycoside is a sulfonyl urea. So why they have chosen glycoside here rather than glimepiride or glibenclamide or glypicide? Next, commence metformin. Why metformin only? Why not others? Okay. Then commence pioglitazone and titrate. Or commence a multiple daily injection of basal bolus. Basal bolus means most often either glargine, basal bolus. You have to start with lisproglargine. You have to add a shorter duration of action drugs like actrapid, and the basal insulins like glargine or even detimer or degludac, any one of these. So which you might think to be appropriate? At 65, you can't tell them rigorous, you can't tell them rigorous exercise and lifestyle modifications, and we don't know in which part of problems they are in. So for that reason, you see to it that I don't really advise lifestyle modification at that age particularly. So for that, the first one is ruled out. Glycoside to commence as 40 mg OD you might think of, and even only once daily, especially at night. Whenever you want to start on any anti-diabetic drug, you should see to it you should see to it that the fasting is maintained. So fasting should be taken care, and in between Dawn's phenomenon as well as Dawn's phenomenon as well as Somayagi effect will start. So you should think, and then you have to administer glycoside, whether you need it in the morning or in the night. Somebody has raised hands. Can they speak? Can they speak?
Hi, sorry, doctor, for
Huh?
interrupting.
Hello?
Hello, sorry for interrupting. We cannot see the slide that you share.
You cannot see the slide.
Yeah, you might need to
Hello, please
like,
speak loudly, no?
yeah, cannot
Hello?
see the slide.
You cannot see the slide.
Yeah, you might need to
The previous
like,
slides you were able to see.
can, but currently no.
We will just wait. Let me ask them again to where is the problem? We will just find it.
Oh, okay, okay, thank
1 minute,
you.
1 minute, 1 minute.
Thank you.
Can you see now? Hello?
Yeah, can already.
Can you see now?
Can, can already.
Please repeat, no?
Can, doctor.
You can see the slides?
Can, doctor.
Yeah.
Can.
If you can see the slides,
Thank
fantastic,
you.
fantastic.
Thank you.
Yeah. Uh, So the first one is out here. They have added this because in addition they have got antiplatelet activity also. It is the same potassium channel blocker, the increasing insulin secretion. It is an insulin secretagogue. All are same like glimepiride, glibenclamide, and glipizide. But here this has got additional antiplatelet. So you might think of adding, especially in the morning, because the patient is already 65 years. So the person might experience night hypoglycemia. So you have to think, but this is shorter acting compared to glimepiride. So you can think of it. Then comments metformin because this is the first drug of choice according to all guidelines. All guidelines, anti-diabetic drug, first drug we administer is metformin once daily whenever there is no, after 3 to 4 weeks, whenever there is no adverse effects like metallic taste, metabolic acidosis, or malabsorption syndrome, or patient complaining of other vitamin B12 deficiencies clinically. I'm not asking investigationally. Everything clinically you should do. Later on come to investigation. But nowadays it is first investigation and then clinical. No, you should not do like that. First, clinically, you should see and only then go to investigations. So, depending on that, you can increase metformin even to 1 gram per day, or even you can use extended release tablets also. Pioglitazone, we normally don't use it because this can cause edema and weight gain. Edema, though this is a poor man's insulin, this is branded as poor man's insulin. What is poor man's angiogram? ECG. Okay, what is poor man's angioplasty? Nitroglycerin. Like that, what is poor man's insulin? It is pioglitazone. It is a wonderful drug because it does not require insulin at all. But the problem is weight gain and edema, and this cannot be used along with insulin. So either you have to use D or E. Okay, so these two are the only options. You cannot use both of them. So that's why we have to think of pioglitazone. Then, in case of basal bolus, the patient should be able to afford the insulin analogs are little costlier. NPH can cause hypoglycemia. The regular one, NPH can cause, Mixtard can cause hypoglycemia. Actrapid, we can use it. And Mixtard we can use, but Mixtard is known to cause hypoglycemia. Whereas the other basal insulins are very fantastic, but their little cost problem is there with these things. So just a glimpse. See, we want to add, why do you want to add metformin? Because this is the first choice for initial treatment with all patients. This is the rule. Oh, globally, this is the rule. Why this bicarbonate medication? It will reduce the glucose by acting on the liver, and improves the body sensitivity to endogenous insulin, and also reduces the absorption of glucose. So it has got multiple actions, so and no, minimal side effects, especially weight gain, hypoglycemia. So these are the concerns. So that is not there with this. It is weight neutral. and also hypoglycemia neutral. So for that, we prefer to use biguanides. And initially, we have to monitor for all these problems and also HbA1c and repeat for 3 months. If it is within normal limits, then continue or up titrate. Or if it is not sufficient, then add glycoside or insulin as the situation might be. Why did I tell LSM in big letters or capital letters? This is because, as I told you, you have to speak about eating habits and physical activity rather than telling them diet and exercise. Remove those words diet and exercise because people know much more than us regarding the word diet and exercise. That's the reason you have to ask them what are your eating habits and what are your physical activity throughout the day. That will give you a conclusion what is really being done and what you can tell them within about 2 to 3 minutes. Why do we want this? They will decrease the risk of developing microvascular complications and macrovascular complications. Because of that, we need this LSM. The other anti-diabetic drugs which can be taught are the drugs which can help in glycemic control, which is cost effective, which has got good patient compliance, and which has got minimal adverse effects. So these are the things what you should think. If at all you don't want biguanides or glycoside and insulin combination, if we do not want this, we can think of all these things. So here you are planning. So why did I use the word here planning? This is because we have taught several things and then we are doing. The antihypertensive drugs need not be changed because Ramipril is a very good drug. uh, Even at 65 years of age, it can take care both of cardiac as well as renal and also blood pressure, the heart, the apoptosis, remodeling, fibrosis, everything can be taken care. Amlodipine is added mainly because the patient is 65. Above 60, they will have isolated systolic hypertension. Three decades ago, for isolated systolic hypertension, if the person is age 60 and the blood pressure is 160 by 80, we would take it granted that it is normal. But now it is not so because of many of these cardiovascular accidents. So for that reason, we always try to keep the blood pressure below 140 by 90. Below 140 by 90 according to today's guidelines. So you have to keep this, and if there is comorbidities, below 130 by 80. So these are the ones what you have to think of. And then Ramipril has got these advantages. Amlodipine is added because it has got a longer duration. How it has got longer duration of action? What is the rationale? What is the thing? How it is longer acting amlodipine? You have to say that. And so normally we use amlodipine or cilindapine rather than the other drugs amongst calcium channel blockers, mainly to reduce the systolic blood pressure, which normally increases by 5 to 10% as we age. So because the guidelines are like that, we want to bring it down. Otherwise, that also might be more than sufficient. And amlodipine and ramipril, both of them should be given at night. Only when the dose is high, then you start in the morning. Otherwise, most often it is given at night. Why it is given at night? We give this AC inhibitors and ARBs at night because this RAS activation is maximum at night. Like your HMG CoA enzyme, this is also activated at night. Suppose you give it in the morning and the drug has got plasma of life about 6 to 8 hours. The drug is not there in the body, so there is no use and RAS system gets activated. So angiotensin 1 is higher. That can cause more of vasoconstriction, etc., etc., and the blood pressure. You keep on giving the drugs, but nothing is controlled. So this is the problem. Why we start ramipril at night after reaching the really good dose. Then you shift it to the morning also, but night dose should be there because you are blocking the RAS activation properly. And amlodipine is given because of isolated systolic hypertension. Why do we want to start it at night? Because it produces edema. And this edema cannot be overcome by thiazide diuretics. Other edemas can be decreased by thiazide diuretics, but this cannot be decreased. You should answer why. What is the reason for having edema with amlodipine? Okay, so this is about planning for a case, how you go through, how you will really be very efficient. You should catch hold of the patient with you only. You should not let them go outside. So for that reason, you have to know how to manage it very effectively. So the next one, uh, we have the data interpretation. The last one, I will not take much of your people's time. Are you able to see all of you? Hello? Are you able to see?
No.
Huh? No? Think one. Now?
Okay, can.
You can see, no? Okay.
Can.
Now,
Thank you.
whatever data is given, you have to interpret it. So how will you interpret? What is the mechanism? How do you think that is right, this is wrong, or whatever it is? So we will see with one particular case, we will see how we can manage this story. A 60-year-old man was asked to attend an emergency department following an abnormal routine blood test. Earlier, he had been feeling well recently. Blood test was taken following recent changes to his regular medication. His past medical history was significant for hypertension only. Current medications were Ramipril 5 mg OD, spironolactone 25 mg OD. He worked as a retail manager, no alcohol, no smoking. And the results were blood for from the emergency department. It's almost all of them are normal. Okay, all of them are normal. Creatinine is little on the higher side. Potassium, of course, it is very high, 7.1. And ECG is also almost normal. So here you have to remember ramipril, spironolactone, and potassium levels. Okay. Now the treatment options. So based on this information, what can we do? The problem here is not with hypertension, but it is with HbA1c and potassium. These are the two problems what we are encountering here. So based on this, what all can we commence? Can we give actrapid? What should we do here? We have to decrease potassium levels and we have to start maintaining his HbA1c. These are the two main areas what we have to really think of, isn't it? Are you following it? Are you people following? Okay. So you have to think these two are the problems what we are what we want to see. What we want to see. So the options are, can we start with actrapid 10 units in 50 ml glucose? Or should we give intravenous insulin infusion 0.1 unit per kg per hour? Can we give calcium gluconate IV or calcium resonium 15 grams orally? Or salbutamol 250 micrograms IV or 10 mg nebulization, and lastly sodium bicarbonate. So think, why have they chosen these things? We have got problem with two things, isn't it? HbA1c as well as potassium. So does it correlate here? Does it correlate? We have to know whether it correlates. The what we have chosen and what the problem is there with the people. Does it correlate? So you have to know the actions of insulin, calcium, as well as salbutamol. So when you know the rationale, then you can come to a conclusion. Come to a conclusion that any of these can be given, or do we have any problem further also. So these are the ones. Again, I repeat, insulin, either directly IV or infusion. Calcium, either orally or by IV. Salbutamol, by nebulization or by IV. Okay. Then lastly, sodium bicarbonate. Why they have added sodium bicarbonate? Nothing is seen there, but still they have added sodium bicarbonate. So you have to know what is the reason for adding all these things. So our choice would be actrapid 10 units in 50 ml glucose, 50% glucose, 50 ml and 10 units actrapid. So you have to combine like this and give IV stat. What's the reason? Insulin action is it will send the potassium into the cells. So hyperkalemia is reduced. This is the reason why we have chosen these things. Why we have chosen these things. This is the reason. Did you understand?
Yes.
Okay, then why we don't want intravenous infusion? We have to wait for a very long time, and this is a short time problem. Okay, this is a short time problem. Acutely you have to manage. This is only for hours, so we don't need this infusion. Next, calcium. Calcium is antagonistic to potassium. Whenever there is a potassium, there is a threat to the heart. There is a threat to the heart. So because of this, what's happening? Because of the threat to the heart, you have to see that the heart should contract properly. So calcium is known to contract the heart very well. So for that reason, we prefer calcium gluconate 10% of 10 ml IV very, 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 very slow. If you just push in, it lands up in arrhythmias and immediate death. That's the reason why we have to give very, very slowly. Next, salbutamol. Salbutamol is a beta 2 agonist. Salbutamol is a beta 2 agonist which will stimulate the sodium potassium ATPase pump via beta 2 receptor stimulation, driving potassium intracellularly. Driving potassium intracellularly, and so we prefer actually IV salbutamol, which can reduce hyperkalemia, but in an outpatient setting or ward-based setting, nebulization is preferred so that we are minimizing the adverse effects like fine tremors, hypokalemic periodic paralysis. Okay, all these or tremors, all these are reduced. So we prefer on a ward setting, we prefer salbutamol 10 mg nebulization. So did you understand why we have chosen only those three and not the other ones? Okay, calcium gluconate 10% 10 ml intravenously. So to stabilize the cardiac myocyte cell membrane, to decrease the arrhythmias which are occurring, and insulin we are using because it will stimulate sodium potassium ATPase pump which allows potassium into the cells, and it should be administered with glucose. Why with glucose? Not just insulin, with glucose, because you should avoid hypoglycemia. You should avoid hypoglycemia, and also you should monitor the blood levels once you start giving insulin at least for next 6 hours. Why sodium bicarbonate? Why sodium bicarbonate? Because of all this, patient might be going on to metabolic acidosis. Okay, so because of metabolic acidosis, you have to give lastly sodium bicarbonate intravenously in this sort of setting. But if you feel that if it is refractory hyperkalemia or patient is going on to renal failure or any other problem, you should give it to the concerned nephrologist or whosoever specialist is there. Okay, so this is with regard to hypoglycemia, managing the glycemic levels and also managing the potassium. Okay, also managing the potassium. Fine. So this is in an overview. I have given you the things here to prevent and all those things. Okay, and in all these cases you have to see this. Now the person is on ramipril and spironolactone. Can you combine ramipril and spironolactone? What are the adverse effects of ramipril? It is an AC inhibitor. The three main adverse effects clinically what we see is, first is brassy cough, dry brassy cough. Second, first dose hypotension. Third, hyperkalemia. You have so many others. You can say all 7 later on. But these three are the most important ones. What you have to remember. Never forget it. So this causes, as such, it causes hyperkalemia. Secondly, they are adding spironolactone. Once they have added spironolactone, it is a potassium sparing diuretic, aldosterone antagonist. So potassium is replaced, it is kept inside the body, and sodium is thrown out. So both put together, it causes hyperkalemia. Amongst all the electrolytes, potassium, we are very much bothered because hyperkalemia is also a problem. Hypokalemia is also a problem. Because of this, you have to be careful the drug interactions, especially which cause hyperkalemia. And also the regular foods which can cause hyperkalemia. The two most important foods that cause hyperkalemia are, one is banana, big banana. Okay, and the second one is coconut water. These two are in plenty of potassiums are there. So for that reason, whenever the patient is on these drugs, tell them not to have these at any cost. Not to have these at any cost, because they may land up in casualty. Nicely drinking these things, they will go and they will see to it that they will be in casualty. Okay, so remember these drug interactions in your day-to-day practice. ARBs with potassium supplements, hyperkalemia, it may go to 7, 8, even 9, or even 10. ARBs and heparin or low molecular weight heparin, these also can cause potassium inside the body. Ramipril with spironolactone, as we have seen in this case, and digoxin and potassium sparing diuretics. These can be used in heart failure, but with monitoring, and also adding hydrochlorothiazide, which can obviate this hyperkalemia, and the potassium supplements can be at an optimum level. At an optimum level. Okay, so with this, I think I've taken all the three in a understandable way. How to have the therapeutic levels optimum for to have a good therapeutic effect. How to plan and manage a case with any of the, I've given you an example. You can have as many as we can with every different cases. And lastly, how to monitor the data monitoring, how to monitor with each one, keeping at the back of our mind, and clinically, how to reduce it, minimizing the investigation, especially clinically. If you are very thorough, then you won't add such combination. And so you are very good at these things, and the patient will also be very happy, and you will also get the satisfaction that you are putting the right medical drug as far as possible to have a good quality of life or whatever God has given. Uh, Thank you for your patient hearing. Any questions? If you